I hope everybody has witnessed at least, maybe I would say 10 to 20 cases in their clinical career as far as like the trainee is concerned. And they have definitely addressed also the issues concerned to the cardiogenic shock. But it is still a big problem if we'll be discussing about the proper diagnosis and management. So, rightly said, the subject that have been assigned to me is a difficult to diagnose and also how to approach it. It has to be a structured way. So I invite the queries from all the attendees who are joining and who have already joined, and I hope it would be very interactive one. And I would also learn by cardiogenic shock. Coming to the disclaimers, I am teaching the trainees all over the world in different examinations, both in Indian as well as European diploma, as well as the DRNB and DM through 360 Critical Care. And I have also founded the Nephro Critical Care Society, which is the global collaboration between nephrology and critical care at the international level. Now, let's start with a clinical vignette. A 68-year-old woman arrives at the emergency department with complaints of dyspnea and lightheadedness. We all have witnessed this type of presentation in our patients in emergency department. Now, on evaluating further and asking the family, her family states that she has a weak heart and report history of hypertension that is being treated with multiple agents. In the emergency department, she is somnolent with cool and mottled extremities. Heart rate of 45 beats per minute, BP of 114 per 71 millimeter mercury, and SpO2 of 88% on room air. So you have immediately put on the 10 liter of oxygen. On ECG, it shows a junctional bradycardia with no ischemic changes. She has crackles diffusely through her lung field with decreased air entry bilateral. Now, this is the short clinical vignette with which we have to evaluate further. Now, what could be the problem she is having and how do you approach? This is a $1,000,000 question in front of me. Now, my talk would be very simple and it would be more of critical care. I am not a cardiologist, so definitely it would be cardiac intensivist rather than cardiologist. There would be many infographics and algorithms to remember the things in a very structured way, and that would be definitely helping you in your training period, also in your assessment at the bedside, and also during your exam time. And most of the things would be evidence based. Now, why it deserves to be a separate class? If I would be saying that cardiogenic shock, does it relate to the heart? That's why we are taking it as a separate class in the step session? No. Rather, I would say this session is mainly aimed at solving many of the problems that we are experiencing at our bedside. As rightly told in the first line, survival of the cardiogenic shock patients, despite all the advances in the cardiac critical care as well as cardiology, has not changed substantially. This is in the recent literature, despite the pathophysiology, the management of MI, myocardial infarction, as well as congestive heart failure have tremendously developed in last, but still the cardiogenic shock patients have mortality around 30% to 50% or 30 days following the diagnosis. So it's a concern for the intensivist as well. Now, let's start with the history. This is the first paper that was published in the 1967, and you can see the author Killip. So anybody who has done internship in the medicine as well as in the final year Harrison, they have read about the Killip classification, and this is the author and this is the article. This is a seminal article that was published almost, I would say, 60 years back. And in that, Killip has divided the congestive heart failure with the dyspnea NIHI classification into four parts. Class 1, class 2, class 3, class 4. It's a medicine part. So we all know class 1, no evidence of congestive heart failure. Class 2, there would be S3 gallop rhythm and bibasilar rails, just we get in our congestive heart failure patients. Class 3 would be pulmonary edema, almost halfway up the lung field. And class 4 is cardiogenic shock. So, Kilip class 4 is cardiogenic shock that was described in his seminal paper of 2-year experience with 250 patients in his coronary care unit in New York hospital, and 19% of the 250 of the patients were in class 4, that is in cardiogenic shock, and believe me, the mortality rate was 81% at that time. Now, then came the NEJM article, again very important article by Forrester as well as Swan, and they have also divided this different classification related to the cardiogenic shock based on the capillary wedge pressure and cardiac output. And you can see here the subset 4 is elevated pulmonary capillary wedge pressure and decreased cardiac output. Indirectly, it is actually, I would say, cardiogenic shock, frank cardiogenic shock. Now, these subsets correspond with the Kilip classes, and mortality rate increased in the subset of the patients with hemodynamics cardiogenic shock, and that was published in 1976. So the first one is 1967 and the second. Now, if I have to define or describe cardiogenic shock in 3 headings. So the first one would be it's a state of inadequate or perfusion due to primarily cardiac pump dysfunction. Try to understand each line. If you remember these 3 points, you can just easily grasp the remaining slides. It is a state of inadequate organ perfusion, primarily due to the cardiac pump dysfunction. Second point, it has multi-factors and it is a hemodynamically complex syndrome due to impaired myocardial contractility. Self like evident with this, like the line itself. And the third point, which is very important, all these things will lead to profound and refractory circulatory collapse represented by 3 things: systemic hypoperfusion, metabolic acidosis, and refractory multi-organ system dysfunction if you are not treating at least at the earliest stage. So these are the 3 highlights of the cardiogenic shock. I believe everybody is clear with this slide. Now, if we will be discussing the epidemiology of cardiogenic shock remains the most common type of shock in the coronary intensive care unit or cardiac intensive care unit. Historically, primary disorder caused by LV dysfunction resulting from acute myocardial infarction is the most important etiology of cardiogenic shock. But try to understand the second line. In recent years, acute decompensation of chronic heart failure has been recognized as the most common underlying etiology. Almost more than 50% of the admissions is for cardiogenic shock. So previously it was acute MI, now it is the acute decompensated congestive heart failure. Maybe the shift in the epidemiology of the patient category increased preventive therapies, and we have also seen the decline in the acute MI incidence over last couple of years, maybe 10 to 20 years. We are more thorough with the early revascularization strategies, and that's the reason why AMI survival is better in our clinical practice. And as we are progressing with the medical management of the heart failure predominantly, so the patients are frequently getting the acute exacerbation of congestive heart failure or decompensated heart failure. And that's the reason why these patients would be coming to our ICU, our emergency department frequently, and that presentation would be frank cardiogenic shock. So that's the epidemiology from the cardiogenic shock. Now, in another article, you have to also read that 60 to 80% is acute coronary syndrome related. And out of that 70% of acute coronary syndrome, STEMI is 70%. 70% of the acute coronary syndrome related cardiogenic shock is STEMI. And these patients, 28% of the SCS patients will ultimately develop the cardiogenic shock, and they have very high mortality, almost 28% to 51% if your patient is having acute coronary syndrome related to cardiogenic shock. And also, not only the heart, also there would be other organ involvement like acute kidney injury. So this is a vicious cycle. So cardiogenic shock would be primarily related to the MI or congestive heart failure related, but also it can involve other organs. Now, the first question for all of you, I hope you should be attempting at least after listening to the first 5 to 6 slides. Cardiogenic shock is most often associated with which LV wall involvement in MI? Inferior, lateral, anterior, posterior. You can all post in the chat box, and Dr. Jhuma can see because I am sharing the screen, so I will not be checking the answers. So if you know the region, then the answer should be anterior wall. If you have answered anterior wall, you are right. And anterior wall is the predominant wall which is supplied by the LAD, and that is the most important artery that would be circulating blood to the whole of LV. And so that is the answer. I would be again going with the second question now only. Percentage of patients with cardiogenic shock that have shock at the initial presentation. So the first time the patient will be coming, patient is in cardiogenic shock and they have also shock. 25%, 50%, 75%, and 90%. The next slides will be based on this slide, the question.
Yeah, so most people have answered 25 and 50%.
Yes, yes. So answer is 25%. Why I am going with the 25%? Because this is a myth people have that cardiogenic patients, cardiogenic shock patients, they will have shock. No, shock will be also like not a very common presentation in patients with cardiogenic shock. I will be explaining in my subsequent slides. So only 25% of patients you will get that patient is having hypotension, shock, and patient is also having frank cardiogenic shock. Now, the definition of cardiogenic shock, clinical definition varies from guidelines to guidelines, from the associations to associations, from European Society of Cardiology to the American Society of Cardiology. But normally, it includes hypotension, systolic blood pressure less than equal to 90 millimeter mercury, despite adequate filling pressures and signs of organ hypoperfusion. So these are the two things that you need to remember. Now, there is a clinical triad in cardiogenic shock. There has to be ineffective cardiac output, tissue and organ hypoperfusion, and normal or elevated cardiac filling pressure. That is congestion, pulmonary congestion. So if somebody is saying that every patient of cardiogenic shock will have elevated cardiac filling pressure, it would be wrong, because there would be also situations when you will get normal cardiac filling pressure, but the patient is in cardiogenic shock. And I would also explaining the little bit detail about cardiogenic shock with another question. It is a true false. Can cardiogenic shock present with hypoperfusion even in the absence of hypotension? True or false? Like yes or no? Can cardiogenic shock patient present with hypoperfusion even in the absence of hypotension? That would be my next slide. So I am just starting with a question. So the answer should be yes. In absence of hypotension also patient can present with hypoperfusion. So the clinical pearls that I want to take to you is a shock, a state of hypoperfusion, both by clinical and biochemical signs of hypoperfusion. Hypotension is not required for the definition of shock state. Very important. And patients in an early shock state can have normal to high blood pressure. So it is a contrary to the current understanding or the common belief through a compensatory mechanism while your tissue perfusion is significantly impaired. Early recognition of hypoperfusion signs identifies high risk patients regardless of hypotension. So if my patient in the emergency department is having blood pressure of 130/70, but if the cardiac contractility is low and I am getting all the biochemical markers of cardiogenic shock, then my patient is in cardiogenic shock despite the blood pressure is holding. Maybe after half an hour, 1 hour, if my cardiologist is not going for the angiography and angioplasty, and my patient is going into frank pulmonary edema, so the patient is gone. Cardiogenic shock is a clinical diagnosis, and hemodynamic parameters like reduced cardiac index, elevated pulmonary capillary wedge pressure are not mandatory in the clinical practice. So these are something I want you to understand, and that would be also applicable in your clinical practice. Now, again, a question. Shock tends to develop earlier in patients with single vessel coronary disease than in those with triple vessel disease. True or false? So if a patient is having single vessel coronary disease, so the patient should be more prone to have shock, or the patient is having triple vessel disease, those patients will be more prone to develop shock. Which one is right? True or false? This sentence. Dr. Juma, you can tell me what is the maximum answers, like the responses. This sentence is true or false? So I would not be taking much of your time. So it is true. Contrary, people will be thinking if the patient is having multiple vessel disease, so patients will be having shock. No, as it will take some time to involve the triple vessels, so the patient will be having collateral circulation. So shock will be taking some time to develop if the patient is having triple vessel disease. But if it is a single vessel disease, like I will be giving you example, left like the coronary artery or LAD. So if it would be blocked, so completely the patient would be having shock from the very beginning. Now, coming to the definitions, I have told about, there are many trials, many societies, so they have their own definitions. So if we're going with the shock trial, it is clinical criteria, hemodynamic criteria. In the clinical criteria, I have already told myocardial infarction complicated by left ventricular dysfunction. Systolic pressure would be less than 90 millimeter mercury for more than 30 minutes, or you are getting, or you are starting some support to maintain the systolic pressure more than 90 millimeter mercury, and also you are getting end organ hypoperfusion in terms of urine output less than 30 ml per hour, or cold clammy extremities. So this is clinical criteria. In the dynamic criteria, cardiac index less than 2.2 liter per minute per meter, and pulmonary capillary pressure more than 15 millimeter mercury. Clear? So this is the shock trial definition. Now, IABP shock 2, that is another definition. Again, clinical criteria, acute myocardial infarction, systolic blood pressure less than 90 millimeter mercury for more than 30 minutes, or you have started catecholamines in terms of vasopressors to maintain the systolic blood pressure more than 90 millimeter mercury, and there is clinical pulmonary congestion and impaired end organ perfusion in terms of altered mental status, cold clammy skins or limb, and urine output less than 30 ml per hour. If you are doing ABG, the lactate would be more than 2 millimole per liter. So this is the IABP shock 2 definition. Now, as per the European Society of Cardiology Guideline 2021, they have again divided into clinical criteria, clinical hypoperfusion criteria, laboratory hypoperfusion criteria. And it is similar to the shock trial as well as IBP shock 2 trial, and they have made it little bit of extensive in terms of hypoperfusion. That is again clinical and laboratory. Now, I would going ahead with another classification, that is SCAI classification, Society of Cardiac Association, and they have divided into A, B, C, D, E. when we are having A, B, C, D approach for all of the major things in critical care. So cardiogenic shock also is having classification in terms of A, B, C, D, E. A is for at risk. The patient would be hemodynamically stable without hypoperfusion, but definitely there would be features of the large acute myocardial infarction or decompensated heart failure risk. So that is A, that is risk is there. Now, second would be B for beginning. That means the patient is starting to have unstable hemodynamics in terms of hypotension, tachycardia, or there would be systemic derangement in the dynamics without hypoperfusion. So it would be beginning of patient getting deteriorated. Now, C is for classic hypoperfusion requiring pharmacologic support or mechanical support, and hypotension is usually present. So you can see here B and C, the lactate is changed. B lactate is less than 2, C lactate is more than 2. So that is the transition that yes, now the patient is in frank hypoperfusion state in the definitive cardiogenic shock. D, you are getting delaying your like management. So patient is now having your shock deteriorated and that worsens or fails to respond to your initial interventions with the pharmacologic support or your IABP, something like that. Now, E is for extremis, that is refractory shock or impeding to cardiac arrest, or patient is already having cardiac arrest requiring CPR. So that would be E. And you can see here, three important things here also just below this A, B, C, D, E. One is congestion. So congestion starts from the B and it increases as we enter into the E. Hypoperfusion starts from the C and it increases till the E. And MODS, that is multiple organ dysfunction, starts from the D and it progresses and ends up with the cardiac arrest at the E. So this is the cardiogenic shock definition in one slide. So I hope you will be remembering as I have made it as a flag shaped things. Now, there is another classification which I would like feel you will be like getting it in a little bit of x-axis and y-axis. Put the x-axis and y-axis in the form of perfusion and congestion. And you can see this classification is named as Forrester classification. Forrester classification, it is 1, 2, 3, 4. And 4 is the worst form. That is, patient is cold, clammy. That means hypoperfusion is there. And wet. Wet means patient is also not getting the perfusion. And the patient is having pulmonary congestion. Your cardiac filling pressures are very high. So if your patient is in the cold and wet group, so mortality rate is increasing and reaching up to 50%. But on the other hand, if you are like having the happy phase here, it is warm and dry. This is Forrester class 1. So it would be warm extremities, adequate urine output, preserved renal function, and normal net. This is well perfused, green light. And in between, you can see warm and wet, cold and dry. So as we go from clockwise, 1, 2, 3, from here it has to be again from the left side, 4. So it is less than 3% mortality, 9% mortality, 23% mortality, and 51% mortality. So you can just make this type of picture in your exam or in your like the understanding. You can just remember these things and can also put your all the intentions monitoring like no dyspnea. You will do the ultrasound at the bed. In the dry lungs, you will get A lines. In the pulmonary, you will get the B lines. And chest X-ray, it would be clear. And in red one, it would be pulmonary edema. So this is Forrester classification. Now, there is another classification which is phenotypic classification. And again, that is interesting. This is published very recently in last 2 years in most of the articles related to cardiogenic shock. The first one is non-congested. So this is phenotype 1, non-congested. Now, you can see the next one is cardiorenal syndrome. This is the phenotype 2, cardiorenal syndrome. That means the cardiac problem is now involving the kidney. And the third one would be also, it would be involving the other organs. And the most prominent one is liver. So it is cardiometabolic syndrome. So you will get all the liver enzymes elevated in this form of cardiogenic shock. So this is the phenotypic classification. So I have given you almost 7 classifications that would be very prominent and clear in its approach. Now, on the basis of phenotyping classification, non-congested, cardiorenal, cardiometabolic, and you can see the mortality rate increases from 10 to 28% to 53 to 56% in the cardiometabolic. Cardiometabolic is almost percentage in the mods. Now, let's just visit this pathophysiology. Why actually cardiogenic shock happens if your patient is having myocardial dysfunction? Now, let's analyze this picture. Myocardial dysfunction happens. It can be systolic dysfunction. It can be diastolic dysfunction. If I am focusing on the systolic dysfunction, as a result of your like decrease in the cardiac output, decrease in the stroke volume, patient will be having hypotension. As a result of that, there would be decrease in the coronary perfusion pressure, leading to the myocardial ischemia. And patient would be having progressive myocardial dysfunction, leading to the myocardial death. As a result of the decreased cardiac output and cardiac like stroke volume, there would be also, along with the coronary perfusion, there would be decrease in the systemic perfusion. But the body was trying to compensate by vasoconstriction. As there is no perfusion or minimal perfusion to the major organs, so the kidney will be trying to do the compensatory vasoconstriction, and as a result, what happened? The sympathoadrenal system would be activated, renin-angiotensin system would be activated, and there would be fluid retention. Clear? Now, on the right side, there would be diastolic dysfunction. As a result, what would happen? There would be pulmonary congestion, increase in the left ventricular end diastolic pressure. As there would be pulmonary congestion, there would be hypoxemia because it's the lung involved. And as a result, what would happen? There would be ischemia to the other organs, to the cardiac, like the system, and there would be progressive myocardial dysfunction leading to death. Now, the story doesn't end here. What happens further if I am just extrapolating this picture to just little bit to the systemic inflammation? The remaining things remain the same. There would be simultaneously also systemic inflammation leading to the increase in the inflammatory cytokines in the form of nitric oxide synthetase, and there would be more release of nitric oxide, and that would be resulting in the vasodilation. So along with the compensatory vasoconstriction, there would be also feature of vasodilatation, and that would be leading to decrease in the systemic vascular resistance. And these things also will be adding up to the problems, the existing problems. So now previously patient is having compensatory vasoconstriction. Now there would be vasodilation. So these type of patients would be having vasodilatory shock plus vasoconstrictory shock. So both two types of warm shock and cold shock, both would be in the same patient. So these patients are little bit of confusion. So you will not be getting it in the emergency department or in your like initial assessment in your ICU that which way you should be actually starting your management. Now, this is something similar to this previous slide, but where you can intervene and what would be your approach to the patients with the cardiogenic shock. As I have mentioned, if you are starting with the coronary revascularization in the form of PCI, so there would be halt in the progress. So there would be decrease in the coronary perfusion if you are not treating, but if you are doing the primary PCI at this point of time, patient will not like land up in the other complications. Now, in the lung pathology or diastolic function, if you have started patient on diuretics at the right time, you have put the patient on ventilation, you have put the patient on oxygenation, and the pulmonary pathology has been taken care of. So the patient will not land up in the pulmonary congestion or refractory hypoxemia due to the pulmonary congestion. You can also go for the SCOP, that is slow ultrafiltration, sustained ultrafiltration in the form of RRT, if the patient is not responding to your diuretics. Now, for the decrease in cardiac output, decrease in the stroke volume, you have to start vasoactive agents, and in the refractory stages, you have to go for the mechanical circulatory support in the form of IABP, LVAD, Impella, so on and so forth. So these are some of the things that you need to do to halt the progression in the pathophysiology state. Now, just for the remember like easily, so cardiogenic shock causes are divided into structure, squeeze, stoppage. So 3S. Structure is acute mitral regurgitation due to the MI complication, VST, free wall rupture, right ventricular infarction, and aortic dissection. Squeeze, there would be constriction in the form of acute MI, blockage of the artery, sepsis, myocarditis, myocardial contusion. There are many medication toxicity like beta blockers, calcium channel blockers toxicities, unstable arrhythmias, and in the stoppage, if it is aortic stenosis, hypertrophic cardiomyopathy, mitral stenosis, any myxoma or cardiac tamponade. So all these three things in the classification, these are the etiology of cardiogenic shock. Now, there are certain precipitating factors as well as etiology in form of acute reduction in the LV pump function. And we have already discussed, you just remember this like red highlighted points, ACS, tachymyopathy, cardiomyopathy, in form of hypertrophic cardiomyopathy, Takotsubo cardiomyopathy, myocarditis due to viral infections, autoimmune infections, reaction to the medications, post cardiac arrest, stunned myocardium, post cardio bypass, pregnancy associated peripartum cardiomyopathy, arrhythmias in form of tachyarrhythmias and bradyarrhythmias, and there would be also simultaneously right ventricular dysfunction secondary to pump failure, that is RV infarction, septic cardiomyopathy, or secondary to the peripheral vascular disease. In the most notable is acute pulmonary embolism. So these are the primary etiology or precipitating factors for the coronary cardiogenic shock. Now, there would be also another etiology table, that is valvular or mechanical dysfunction. I have already explained endocarditis, ruptured papillary muscle, prosthetic valve dysfunction, VST or free wall rupture. So we will be getting this if we are in the proper cardiac intensive care unit. Channel blockers, digoxin, antiarrhythmic toxicity, cardiac tamponade, and also different toxidromes in the form of beta blockers and calcium channel blockers. Now, there is also another re-stratification. Is there anything that we can get at the bedside that would be pointing towards that my patient is not going to be like getting best results despite all the proper management? So one of the score is IABP SOC 2 score. This is a first score that is validated against internal and external registry data, and that is the prognosis estimation in the catheterization laboratory, like in the cath lab only. You can get this score. One is age more than 73 years, previous stroke, glucose at the admission is more than 10.6 millimole per liter, creatinine at admission more than 132.6 millimole per liter, arterial lactate more than 5 millimole per liter, and TIMI flow, that is the flow after you are doing the stenting, less than 3 after PCI. So if your score is submitted, and it can be divided into low, intermediate, and high risk categories. So if a patient is in the high risk category, so mortality is almost touching 60%. There are other prognostic scores also. I'm not going into detail. So one is SAVE score, one is ENCOURAGE score, and one is CAD SOC risk score. And IABP SOC 2 score I have already explained. So just remember, there are certain prognostic scores that can be used in your cardiogenic shock. Now, you have discussed about the classification, the causes, the etiology, the pathophysiology, the definition. Now, how to assess any patient with cardiogenic shock? We have already discussed about the definition. It is again revision. We have already discussed about the phenotyping. That have been also discussed. We have already discussed about the causes of cardiogenic shock. That also clear. Now we need to do some investigations for the etiologic assessment. We need to do standard 12 lead ECG, X-ray, transthoracic esophageal. This is a focus that we need to do for the heart and also for the lung and pleura. So that we all do in the emergency department in your ICU. So that is also a standard investigation or examination that we need to do. Also, if you are suspecting that my patient is having aortic dissection or pulmonary embolism, definitely I would subject my patient to the CT. Now, after that, is there any role of hemodynamic monitoring? Yes, I need to put one central line if I need to give some fluids or start some vasopressors, inotrops, arterial catheterization, monitor invasively the blood pressure. If my patient is suspected to having right ventricular infarction and I am in a coronary care unit, full-fledged, fully the set coronary care unit, so I should be doing also advanced cardiac output monitoring and also SOS pulmonary artery catheterization. So that would be the approach if I'm getting a patient with cardiogenic shock in my ICU. Now, I will be giving you some of the steps. As we are in the step, so I would also give you the steps, how you should approach a patient with cardiogenic shock. So let's start with the step one. First one, first things come first, that is urgently resuscitate. Patients with prolonged cardiogenic shock, if is in my ICU or in the emergency department, they need to be ventilated after putting the patient on HFNC or BiPAP, whatever you have tried. But that patient needs to be ventilated in spite of normal oxygenation parameter. And we know the advantages of decreasing the myocardial oxygen consumption when the patient is actually failing. If you are planning to do the intubation, though the patient is having hypotension, so try to use some of the cardio safe drugs, that is etomidate, ketamine and fentanyl. Those patients who are not in clinical heart failure, so you have to give a challenge of fluid, or you will be going with the cautious fluid resuscitation with proper hemodynamic monitoring. So in your exam, if the examiner is asking you this type of thing, so you have to use this technically correct or diplomatically correct answers. Cautious fluid resuscitation with proper hemodynamic monitoring. Now, the golden hour in cardiogenic shock. Everything is right now having a golden hour. Maybe it is in trauma, maybe it is in sepsis, maybe it is in like the neuro or like acute ischemic stroke. So in cardiogenic shock also, it is a golden hour. How you should go ahead with the golden hour approach in cardiogenic shock? You have to start with the initial approach with the clinical examination, then echocardiography, all the blood test. Then you have to identify the etiology in form of whether it is acute coronary syndrome or acute decompensated heart failure. Then, as I have told you about the prognostic stratification in the form of the classification by the SCAI, A, B, C, D, E. I have already told you. Now, then we will be starting with the management in the form of vasoactive agents, oxygenation support in form of HFNC or BiPAP, or patient would be on the ventilator. Fluid resuscitation, that would be guarded with proper hemodynamic monitoring. Then I would call or start preparing for my cath lab. Now, at that time, there would be a shock team and the patient would be shifted to the CCU with proper hemodynamic monitoring. And if my patient is not giving time for the angiography, angioplasty also, I have to put my patient on mechanical circulatory support. I will be discussing mechanical circulatory support. Now, further, I would also continue to monitor my patient in the CCU with proper hemodynamic parameters. Now, we need to target the sweet point in the emergency department in our initial assessment or resuscitation. You can just remember that we need to have our cardiac index at the level of 2.2 or more than that. Less than 2.2, as per the definition, it is a cardiogenic shock. So, if my patient is above 2.2, but if it is below this line, so maybe I have to give some fluid, or if it is above the line, but the cardiac index is less, as well as the edema picture is there. So I have to some dialysis and vasodilatation. So this would be the graph which I need to be keeping my patient. This is the sweet spot in the cardiogenic shock. Now, are the targets met? If it is not with all my medical management, I have to go ahead with the revascularization and mechanical circulatory support. Now, step two. Step two, I have to take a focused history after the resuscitation part and start quick examination. I have to also think about the other causes of chest pain with shock. It's not always that every chest pain and hypotension would be MI or congestive heart failure. So it could be pulmonary embolism, pneumothorax, cardiac tamponade, aortic dissection, esophageal perforation, pneumonia. Step 3 would investigate urgently to confirm the cardiogenic shock. And we all know we have to send cardiac enzymes, ECG, and that has to be serial ECG, chest X-ray, hemogram, electrolytes, FBG to look at the lactate as well as the other parameters. 2D already discussed, and POCUS. POCUS would be all taking care of the lung, pleura, and heart. Now, somebody may be asking, what is the role of echocardiography in cardiogenic
You have
shock?
3-4 minutes.
Yeah, I will be just finishing. Yeah, no problem. Yeah. You
We
have
have
started. So we have to evaluate the overall systolic performance, delineate the regional wall motion abnormalities. We have to also rule out some mechanical causes of shock and right ventricular infarction. Step 4, we have to ascertain the cause of cardiogenic shock that I have already discussed. Step 5 would be the medical management, and we all know the management for the AMI. So here, most important thing, you have to avoid beta blockers and calcium channel blockers. Thrombolysis, if your patient is in hypotension and there is frank cardiogenic shock, maybe it is not very effective. But if you are not getting PCI, better to give thrombolysis. Now, step 6 would be advanced hemodynamic management. And I have already discussed, you have to just titrate your norepinephrine, dobutamine, and there are other pharmacologic agents in the form of levosimendan and milrinone. So this is one slide which you can just refer for the afterload reduction, preload reduction, and contractility. So you can see here norepinephrine, vasopressin, crystalloids, dobutamine, levosimendan. And these are the classification of the inotropes and vasopressors. I know everybody knows about it, just for the sake of completion. Now, coming to the medical support, if I am thinking about my patient is not improving with all this management, definitely now there is role of mechanical circulatory support. And what are they? Just this slide is enough for you. There would be pulsatile and there would be axial flow, there would be centrifugal flow. And in the pulsatile, it is IABP. Impella is the axial flow. Centrifugal flow is either patient would be posted or like put in the VA ECMO and tandem heart. So I'm not going into detail. If somebody is interested to go into detail of the mechanical circulatory support, they can take the insert of this slide. But this would be something for the completeness sake. So now there is a proposed algorithm. So if my patient is in cardiogenic shock and cardio index is less than 0.2, so I have to see whether the cardiogenic shock region is LV dominant, RV dominant, or biventricular. And on that basis, I have to think about whether my patient needs Impella or inotropes ventilators or some form of VA ECMO. So I'm just going into the last 2-3 slides related to the evidence. Till now, though we have the plethora of mechanical support, but the guidelines, the literature is silent that whether we have got the right mechanical circulatory support for our cardiogenic shock patients. Finally, step 8B, you have to go for revascularization. There is no other definitive therapy rather than the revascularization. And all the studies they have shown, if your patient is going for either primary PCI or CABG, so the mortality benefit is almost touching 20%. And you have to also think about taking some fluid out if your patient is in the cardiac tamponade. So revascularization, whether you should go for multivessel PCI or only culprit lesion PCI. So again, that is a questionable mark. Till now, the literature is not very clear, but preferably you should go for the culprit vessel first rather than targeting all the vessels in the same setting. So the last slide, in one slide, I would be just summarizing my presentation. Let's start with the cardiogenic shock management in form of etiologic therapy, optimizing the hemodynamics in the form of improving the tissue perfusion, improving the pump function, and also taking care of other organ dysfunctions. So A, B, C approach. If still my patient is not getting better, So I have to think about acute mechanical circulatory support. So not going into detail whether you have to call it a day by just discussing with the family, despite your LVAD, Impella, or like a tandem heart, you are not getting better treatment. You have to counsel the family for the palliative care. So now the concept of hub and spoke model is there because every patient is different. So you have to go for personalized therapy, and that's why decision making has to be done by a multidisciplinary SOC team. So in conclusion, rapid recognition with multimodal evaluation by ECG, biologic and echocardiography tests that allow early and appropriate management, and that would be improving the survival. Recent classifications by different societies, associations, they better stratify the mortality risk, and that is useful to guide the management. Cornerstone in patient management is treatment of the cause of the cardiac insult in the form of coronary revascularization by either PCI or culprit lesion in the case of AMI. Symptomatic management you need to do with noradrenaline is the drug of choice, and inotropic is the dobutamine is the drug of choice. Management of other organ failure has to be also done along with mechanical ventilation and RRT. Despite all the literature suggesting mechanical assist device, still we do not know which one is the right technique and what is the right time. Thank you very much for your patient listening.
Thank you, Dr. Tapas, and we can have some discussion in the next
Yeah.
10 minutes. The contestants can, sorry, the delegates can put their questions in the chat box and we can take it up. So, Dr. Tapas, there is a question here you can see
Yeah.
in the chat box.
Yeah. So I would be with the questions. Yeah. So from the last question, I would be starting that epinephrine or dobutamine, which is better? So dobutamine is better. Epinephrine and dobutamine, there are multiple trials that have been conducted, and epinephrine has shown to be less effective, and also there would be increase in the lactate, and the inotrope choice is always dobutamine. And if the patient is hypotensive, yes. So there are two concepts. If the patient is properly fluid resuscitated and you are starting dobutamine, the patient's BP will not fall. If the patient is not fluid resuscitated properly and you are starting with the dobutamine, then there is a high chance of patient would be getting hypotension. Dobutamine or milrinone. Milrinone, the literature, the trials, and the practical experience is more with the dobutamine. So that's why most of the literature they suggest that the drug of choice in terms of inotropy is dobutamine. And then moving forward, the inotropes already discussed. Then I think all the answers, the questions they have mentioned. First choice of inotrope. Inotrope is dobutamine. Vasopressor is NORAD. Atrial fibrillation in patients with cardiogenic shock. Choice of rate control. So it's a difficult question. So if the patient is previously having atrial fibrillation, if it is not acute, so maybe we need to go ahead with the rate control. But if the patient is having chronic AF, so at that time, maybe we need to first check the rhythm, because if you are targeting the rate immediately low, so there would be chance of the embolus, if there would be any form of embolus in the left atrium, that would be dislodged. So it again has two or three subsets. Patient is having the new onset atrial fibrillation, patient is having like the chronic atrial fibrillation, then your choice of treatment and also choice of therapy would be changed. When we should go for levosimendan? So levosimendan is previously people were starting to use it before dobutamine, but all the literatures they have suggested that it is one form of inotropy which is having less change in the heart rate. So dobutamine, if we have used it, we all know that there is chance of patient getting tachycardia as well as hypotension, as somebody has mentioned. But levosimendan has less effect on the hemodynamics because the mechanism of action is calcium sensitization. So that's why it is slightly better in terms of the pathophysiology or the conceptual thing, but the literature is not very robust for the levosimendan. Second vasopressor of choice for the vasopressin, norepinephrine, vasopressin. Dopamine is out and adrenaline is of not like much use in the cardiac unit related to the vasopressor. What would be the up time to perform CAG in shock patients at the earliest? People say that you should do it within like you can start from 120 minutes to the 6 hours up to. But if you are unable to do it also, you can go ahead and do it within first 24 hours. The chances of getting better result is also still there. Though as the time progresses, maybe the recovery and the myocardial like salvage would be less. Dopamine, no, Dr. Hari, I would be very sorry to tell that dopamine has many side effects we all know. So dobutamine and dopamine, if you both do, dobutamine also would increase the heart rate and dopamine also will increase the heart rate. And there would be high chance of arrhythmias if you are adding the two things. NT-proBNP, it has high sensitivity if the patient is not having like chronic kidney disease or any other dysfunction. NT-proBNP is very much sensitive as well as specific in the congestive heart failure, provided that you are not having any other organ dysfunction. There are many new things that is coming up in cardiogenic shock, like the shock team, the mechanical circulatory support, then the time of for doing the PCI, whether you should do in the same setting that I have mentioned in one of my slide, the culprit vessel, only that vessel, or also the like all the three vessels at the same setting. So there are many confusions till now also there that whether you should do all the three things. PA catheter, no, I don't do, and the literature is also keeping it at the last. If you are so well versed with putting the PA catheter, and you are all the residents, all the nurses, those who are working, they are well versed with the calibration as well as the monitoring part, then only put the PA catheter, or else literature is not very robust or like no suggestive for PA catheter. Cardiorenal complication causing AKI, when we should do? Yeah, we need to do the fluid resuscitation properly and avoid the contrast induced nephropathy. I agree. If you are putting the patient in the cath lab and you are doing angio, so the chances of patient getting AKI is very high. So preventive therapies as well as proper hemodynamic monitoring has to be there. Anything, friends? I hope the message is very clear that cardiogenic shock, we need to very thorough. We all discuss a lot about the septic shock, but the cardiogenic shock is somehow many confusions are there, and I have tried to touch upon most of the things that is something difficult to understand.
Yeah, thank you, Dr. Tapas. Yeah, you're indeed right that cardiogenic shock is quite a neglected topic, but it is very important, and we deal with it every day in the ICU. So thank you for that wonderful talk. And I have one small question. What is your experience with levosimendan use?
Madam, I would be very honest. Dobutamine suffices everything in cardiogenic shock management. So putting one drug which we are not very much conversed with, and my nurses and my junior doctors as well as colleagues, they don't know the exact mechanism and how we should be titrating the dose. So if you go through the literature, the dose is also 6 milligram to 12 milligram loading followed by 0.1 milligram per kilogram per minute. But we do not know exact titration, how to like move up in the scale or go down in the scale. So little bit difficult to promote levosimendan in current scenario, but it has its own advantages and we all know.
Yeah, but we know that we have also seen in children we have lot of side effects with dobutamine, and especially because they already have tachycardia. So we rarely use dobutamine nowadays. and only except for cardiogenic shock, like you have mentioned. But we do have supply
Yes.
of levosimendan, and we have used in a couple of children, and uh, it has. I mean, we haven't had a lot of issues with it. So therefore, I was wondering that because it has a less lesser uh, side effect profile. I mean,
Agree.
so
Agree, ma'am.
it may be better drug than dobutamine in
Yes.
terms of side effect profile. Yeah. Okay,
But
thank you so much.
yeah.
If there are no more questions,
Yeah.
yes, there's a last
Last
question.
question for decongestion. What is the maximum dose of Lasix? You can go up to 180 milligram. In the literature, they have used 180 milligram. But I would be very honest, like giving a small, like no peanut, 20 milligram, 10 milligram, and expecting that my kidney would be like starting to pee and my heart would be relieved of the fluid is actually something we need to stop practicing. So better to go ahead with the cardiorenal syndrome in the form of 80 milligram, 160 milligram, something like that.
Yeah,
Bolus or infusion? Yeah, madam. Yeah, please.
this last question. I think this is important.
Yeah, Lasix bolus or infusion. It's always if you are thinking that my patient is in cardiorenal syndrome or fluid overloaded, so it has to be with the bolus, and after that you can continue with infusion. But bolus has to be there. You have to hit hard and hit fast.
Okay, thank you, Dr. Tapas. And I think we
Yeah,
have done a lot of questions. And
yeah.
I thank the participants for patient hearing. And so we close the session. Thank you so much once.
Thank you. Thank you all of you for your patience.